we're going to get going now. If you have any questions, send us a chat. Other than that, you're basically going to be able to have polls, chat, blah, blah, blah. Mac, let's take us on. By the way, before we get started, we got two co-faculty here. We got Mira Kodegal from Cincinnati Children's and Justin Huntington from Akron Children's. They have a couple of cases on here, and they're going to be helping us out here. So Mac, take us away.
Let's get started. Let's get the cases presentation. And Barry Newman started our chat, and he spent a lot of time at the microphone in the old days during this session to offer his opinion. So I hope he will continue to do that. All right. Our first case, you're asked to place a gastrostomy tube on a 36-week gestation, 4-week-old newborn who has an inability to tolerate oral feeds because of oropharyngeal dysfunction. The infant seems normal on your exam, so you recommend A, open stem gastrostomy, B, a Ponsky gout or a PEG tube, a laparoscopic U-stitch gastrostomy, a laparoscopic stam type gastrostomy, or something else that you can create and invent. So we can get the audience to start voting.
All right, so let's see what the audience says. So Ted, you let me know how this works. Am I going to see them all pop up at once, or you let me know how this works? Right now,
no, as soon as you're ready to go, we'll close the poll out and then we can show the results.
Ah, got it. All right, so let's give everyone about a few seconds here. In one-word answers, Mira, what do you do? Justin, what do you do? Mira?
Stam gastrostomy, laparoscopic.
Me too. Justin?
Exactly the same.
Mac?
U-stitch gastrostomy, baby.
Okay. So Sharif Emil says, 4-week-old preemie, what's the hurry? Ooh, do you do any G-tube? That should have been, that's your E right there. Great point that maybe we're too quick to do G-tubes. Exactly. So there we go. So they blocked me because they don't want my answer, because usually my answers are invalid. So the most common, 49%, laparoscopic stem gastrostomy. So Mac, you're only 37%. Most of the people agree with Mira and Justin and myself. So I think Sharif brings up a very interesting point. Diana Farmer says laparoscopic assisted PEG. Interesting. So that's another option. Is that's the sort of a combination of a B, CD. So Mac, talk us through what's going on here.
Well, again, I think you showed the results. It looks like the two went. It's interesting that most people do laparoscopic gastrostomies, and most like the stam type, and then a large group, 49%, like the U-stitch, and then other people are being innovative with something else.
So just since everyone can't see everyone else's chats, I'm going to read them here. And guys, text me. I don't think you can see everyone else's chats. If I'm wrong, tell me. So Barry Newman says, why stick a scope in the abdomen? There's no reason to stick a scope in the belly. I disagree with you on that, Barry. So Sharif says, operate first, ask questions later versus ask questions first, then operate later. A lot of people suggest, at least in the US, we do G-tubes way too much. And what else we got? So those are some good answers. Why a U-stitch versus stam? Steven Shu says, how big is a patient and when do you do a G-tube? So there we go. So those are some things. People talking about granulation tissue. So Mac, talk us through.
Well, in an old paper I wrote looking at all 3 different techniques, including T-fasteners, the U-stitch technique had less granulation tissue and more closure of the gastrocutaneous fistula when you remove the tube. But the stam technique is secure. You got stitches holding it in. You don't worry about the U-stitches coming out and losing access. So, but with that said, I think, why don't we move ahead, Todd?
Okay, go ahead. There you go.
All right. I think I hit it twice. So during your laparoscopic gastrostomy, whichever way you wanted to do it, you turn the scope down toward the pelvis, and you see a large right patent processus vaginalis and a small left one. You're doing a G-tube, but you've turned and you've looked, and now what?
So while
A,
everyone's
bilateral
answering,
laparoscopic.
this
A,
was
bilateral
Mira's case.
laparoscopic.
Oh, sorry,
What?
sorry, Matt. Go ahead.
B, A, laparoscopic bilateral hernia repair. B, bilateral open hernia repair. C, no repair, silly. Or do something else.
Okay, so while we're waiting, I think it's interesting, Mac. It's something for us to talk about next year. A lot of people are saying, why do you need to be putting a G-tube in this kid? So I know that the Rachel Rosen from Boston says, Todd, you put too many G-tubes in. I know when Carolina Milan from Argentina came and visited us, she said you put way too many. And so maybe in the States we put too many in. So everyone wants to know, is it a boy or a girl? Mira, was this a boy or a girl?
The boy.
Boy.
You may notice that Mike Chen also noted that there's a vase.
There's a vase.
Yes, Mike noticed there was a vase. Way to go, Mike.
Yeah, not too many girl vases, but yes. No glory in, okay, so we have all these things.
We're still going backwards.
Rick Pearl. By the way, like I said, if you really want to say something and you're not feeling adequate in the chat, raise your hand and we'll bring you up here. Rick Pearl says, talk to the parents if you want to repair. So that would be a D, something else. I think that's a reasonable thing. Says Whit Holcomb published a study of, this is Sharif Emil says, Whit published a study of exactly that scenario. Incidental non-symptomatic PPV, less than 10% ended up becoming symptomatic hernias. And then Justin or Mira, if you see any other comments you want to hit on, or Mac, let us know. But other than that,
all right. So what did we get on the voting?
So the
There we
voting
go.
was 57% said do nothing, and 30% said they would do a bilateral laparoscopic hernia repair. So it's a close race, but most said nothing. Are we going to ask Mira what she did or not yet? I don't want to disrupt your flow.
But no, Mira, let's tell us what you did. Here we go.
The kid was a preemie, and so I didn't want to extend the anesthesia. We weren't consented for a repair, and so we did not repair it at that time.
And
Okay.
Ted, if there are hands raised, just bring them up, man.
So a year and a half later, the patient has to go for gastrocutaneous fistula closure because you did the laparoscopic stam gastrostomy. And because you were curious about those patent processes, you turned the scope around.
What?
Ta-da!
So this is, Mira, talk to us here.
So I promise it's the same kid, and I actually thought maybe I was hallucinating, and I went back and re-looked at the pictures I took 2 years previous. And we, like a lot of the discussion has been, we didn't plan to go back to the operating room to repair the hernias, but I mostly thought I was crazy. But then I went back and looked at the old pictures, and the old pictures were the ones you saw. The pictures obviously look terrible quality, but yeah, they were both closed.
So John Draw says it's magic.
And then I guess at least 70% are going to say no based on the previous answers. But anybody
Everyone
surprised?
Is saying, wow,
that
magic. How do you explain this? Everyone's going crazy here. All right. Are you surprised? Throw it up there, Ted. Can we do that one? Are you surprised?
Can I answer the question about
Should
why?
be
I
up.
put it
Yes,
open?
Mira, I knew you wanted to answer that. Go ahead.
Parents were really concerned about it. We obviously didn't put the scope in to do the GC fistula closure, but the parents were really concerned about it and wanted to repair the hernias. And so we put a scope in to see if the hernias were there, and we're going to do a laparoscopic repair and then deal with the fistula at the same time, since he was already undergoing an anesthetic for the fistula repair.
Okay. Everyone is so surprised, but I don't know if we have a poll. It looks like not. So I'm hearing that everyone's surprised. Like,
do we have a vote, Ted? Do we have a result?
The
of
poll
yes
is
or
up.
no?
People are voting. Let me go ahead and close it out, and I'll show
cool.
you the
I just didn't
results.
see it. There we go. Whoa!
There we go.
72% are not surprised? What? Tell us why you're not surprised, because I had no idea that these things close on their own. So do they close on their own? So what? Exactly.
We're going to go ahead, Todd.
Just as we said.
So
But
is it
Sharif,
less than
I thought that meant that they
10%?
just didn't get symptomatic. They actually closed. Mac?
I was going to move ahead to the next case. We want to make
Okay.
sure we get through them
Go
all.
ahead. Go
Okay.
ahead. Go ahead.
All right. you do a prenatal consult on a 30-week gestation male fetus in your clinic, and it seems they have duodenal atresia. After birth, you're called because now the NICU nurse says she's unable to pass an orogastric tube, and it seems to coil up in the chest. On your exam, the baby also has no anus. So now what are you going to do? Esophageal atresia repair, now followed by duodenal atresia repair and colostomy in a day or two. Esophageal atresia repair followed by duodenal atresia and colostomy a few days later or a week later. No, you're going to fix the duodenal atresia first, followed by colostomy, and wait on the esophageal atresia. Or do them all at one setting. Let's fix the esophagus, let's fix the trachea, fix the duodenum, fix the colon, or colostomy, or something else. So let's vote on this one, and Todd, open it up for chatting.
Yeah, everyone's still talking about the last case, but I think, again, come on in if you want to while we're waiting. You know, the question here is, you know, Justin, this was your case. Talk us through, don't tell us what you did, but talk us through what you were thinking about.
Well, I think the big thing that changes this compared to having just EATF or duodenal atresia is, like, this can potentially turn into a more emergent situation because you have a gastric outlet obstruction and you have an open fistula that's putting air into the stomach. And some of these kids can run into respiratory issues because of the gastric distension. And then the other big issue is, you know, the type of anorectal malformation, if you can get by with just dilating, like a perineal or vestibular, versus other anomalies. And then the other issue is like the size of the child, how they're doing clinically. So I think there's a lot of factors that sort of weigh into your decision making here.
All right, so
Justin, a lot of the comments have been, how sick is the kid? Is the kid unstable? Agostino said the TEF is what's going to kill the kid, dummy. So what? Tell us about how this baby was.
Very stable. And I think they're prenatally diagnosed with duodenal atresia. Everything else was a surprise, but clinically stable, maybe mildly distended, but not ill and on room air. I had a second one recently that was intubated and on positive pressure. That also may change how your urgency to dealing with it too.
Ted, can we see the results and then we'll keep discussing?
all right.
So
Yeah, go ahead, Matt.
No, you.
Okay, so it looks like I didn't know you could see these. So Matt, so 45% said they would do everything at the same time. Interesting. So all the repairs, so the esophageal atresia and the duodenal atresia and the colostomy all at the same time. The second was to do the esophageal atresia and then wait to do the duodenal atresia repair and colostomy. I think everyone agrees to, at least most people agree to do the DA and the colostomy at the same time, but maybe do those later. Oliver, I see your hand up. I don't know if you still want to chat. If so, Ted, we can bring Oliver up. Matt, go ahead. Do you want to ask Justin what he did? Or
Well,
not yet?
10% said something else, and I wondered if somebody could tell us what the something else might be.
What's the something else? Let's see. TEF and gastrostomy later, and then sigmoidostomy. Ivan Rivas says that. Ivan Rivas. So then, okay, so we got a lot of comments here. 30 weaker, tough, interrupt the fistula, G-tube, colostomy all at once. Takes what the defense gives you. All right. All right, Oliver.
So in this case, Justin, you did the esophageal atresia TEF first. Is that right?
Yeah, I mean, I'm kind of, I think maybe it's Sharif that said, you know, it's the TEF that's the real problem. And to me, like, that's really the thing you have to ligate. So that's sort of how I've approached them. Interestingly, I think the largest series looking at these, the like survival was highest of fixing the duodenal atresia first, but there may be some selection bias there as well. But I do the like Fogarty through the fistula and inflate the balloon and then fix the TF. And then this is like the one situation where I use a transanastomotic decompressive NG and make sure no one moves it, and then go back like 48 or 72 hours and do the rest of the surgery in a stage. But I think like in a well, like full term child, if you think they can handle the surgery, I don't think it's totally unreasonable to do it all at once either, because I don't know that we really know if there's an advantage to, you know, fewer anesthetic events versus length of anesthetic event, or if it makes a big difference. But to me, it's just a lot of surgery at one time, so I've broken it up.
Well, let's ask the question, would people approach the esophageal atresia thoracoscopically or with a thoracotomy? Thoracotomy A, thoracoscopic B.
And while we're waiting for this, if people can tell me, can the panel, can all of you attendees see all the comments? Because I think most are being sent just to the panelists, so I can read them. It says unrepaired duodenal atresia puts your fresh esophageal atresia repair at risk. That's what I said. That's what I agree with that. But fix the esophageal atresia. Make it. This is Aaron Jensen. Make a G tube and a colostomy. Duodenal atresia repair next week. I am sure the heart is not normal. Depends on the size. A lot of people saying depends on the size. Now we're talking about thoracotomy, thoracoscopy. Okay, Sharif says he can see the comments. Yeah, so if everyone can send all comments to all panelists and all attendees, then everyone can see your comments. So Mac, talk us through.
Well, let's see the results. Let's see the results.
Okay. Go ahead, Mac.
Well, so 68% say thoracotomy and 32% say thoracoscopically. I'll just say, since I've asked this question a lot over 10 years, thoracoscopically is slowly going up.
All right. Justin, what'd you do?
This is about the only thing I don't always do MIS, but I just did like a posterior muscle sparing thoracotomy.
So I think most of the people on here agreed with you and would not have done this. What's that, Justin?
I don't think there's a right or wrong, and it probably depends on your, you know, ability and what you're more comfortable. Because I think at this point, there's some people that are more comfortable with one or the other, and your outcomes are probably more dependent what you're accustomed to doing.
Sharif Emil says 40% of MIS convert to open. Where's that data from, Sharif?
Sharif said that at this session 3 years ago, yelling at Steve Rothenberg. Yeah, I remember that.
I want to see that data. Okay.
Yeah. So how about this? Would you leave a transanastomotic tube or not? Justin told us he did for a particular reason. I guess I was asking this more routinely. If you do esophageal atresia, do you leave a transanastomotic tube or not?
I think it super depends on all the other questions you've asked before, right? Are you doing the G tube or you're not doing the G tube? Those sorts of things. I think data suggests that transanastomotic tubes are associated with higher leak and stricture rates, although that can be confounded by indication. And so there's a whole lot of debate about that. But I would not routinely, but if you weren't going to do a G tube in this case, because the kid didn't tolerate you getting that far, then I might consider it.
Or Justin, why did you, so the other issue is the kid has a duodenal atresia still, right? So it's a little bit of a difference. Go ahead, Justin.
In this situation, you either, in general, I don't, but for this one, you either have to decompress the stomach somehow. So if you want to do a G tube at the same time, although controversial whether that decompresses as well as an NG, or you do a decompressive NG, or you do the duodenal atresia repair at the same time. But you've got to do something so you don't have distal obstruction below your anastomosis.
Totally agree.
Let's see the results. Let's see the results, Ted, if we could.
Pretty close.
57% say yes, and 43% say no.
So Matt, can I just clarify? I just want to clarify. There's two debates here. One is, do you leave a transanastomotic tube? The other is, do you leave a transanastomotic tube if you still have a duodenal atresia distal to your repair? So it's not, do you routinely leave it? It's in this kid, would you have left it? Okay.
Yeah, and I was asking it a little bit more generically, but you're right. And this kid is a little different. I agree. Okay, here's another case. Thanks, everybody. All the comments have been great. Thank you. 14-year-old male presents to your emergency department with 4 weeks of shortness of breath and exertion and some right-sided pleuritic chest pain. He's a hockey player in Western New York. In the emergency department, he's asymptomatic by the time he gets to the ED, and he's saturating 100% on room air, 80 on his heart rate, and his chest x-ray shows that didn't show. A small right apical spontaneous pneumothorax. And so you know what the question's going to be. Your next step is, let's see. You get a chest CT scan. You admit the patient and give him O2 supplement therapy. You get something sharp and aspirate the pneumothorax in the emergency department and send him home. You place some sort of chest tube and admit him. Or you just can't stand it and you go to the OR for a VATS and an apexectomy and pleurodesis. You just don't want to play around. So let's get some comments while we wait and get the results going.
Okay, so we got New England, Shannon Acker says New England Journal paper says observe in DC from the emergency department. Shannon, what do you know? Barry Newman says, or nothing now if asymptomatic. Everyone's seeing these now, which is good. Everyone's writing to the attendees, which is great.
And Phil Frickman, he had symptoms before he got to the ED.
That's a great point, Phil. It's a good point. All right, so what do we got here? Let's see the results.
There we go. So 53% would admit with O2 supplement therapy. 21% would aspirate, and then fewer on the other ones. So admit with O2 therapy.
So I agree. If someone comes to the ER, they're not asymptomatic. So even if they were feeling better, they were still symptomatic.
He probably was afraid we were going to do something to him, and so he told us he had no symptoms once he got to the ED.
Okay.
All right. Okay. So in this case, the patient was sent home because he had no symptoms. They did a second chest x-ray, and there was no change. He went home with no therapy. However, 1 month later, he presented with 1 day of left-sided pleuritic chest pain and shortness of breath on exertion. Vital signs are stable, and chest x-ray shows a moderate left-sided spontaneous pneumothorax. Mira?
I mean, I think I would do the same thing, but I do think you have to have the conversation about the fact that this kid probably has blebs and, may at some point need intervention. But on an initial pneumothorax, and if they're stable and the chest x-ray is fine, I would repeat it in 4 hours and send them home.
All right, here are your choices. Same as before. So now you've got a second spontaneous pneumothorax on the contralateral side and a healthy teenage boy athlete. Everybody vote and chat at the same time. Home or observe, Barry says.
Interesting. Mike Chen says family will want something done. Observe without sending home, apical blebs, unless they can't breathe. You know what's interesting though? I have not seen a spontaneous pneumo in extremis. Have other people seen that, where you get like a tension pneumo from a spontaneous pneumo? Usually it's different. Yeah, a lot of people are saying that. Look at that. Trey Eubank says he has seen it. Go ahead, Max. Sorry.
I had a hospital board member's teenage daughter come in with a tension pneumothorax, and I got stopped to go talk to the board member rather than take care of the patient, and I had to run to put a chest tube in. So I've seen that.
And Mike says I'm not old enough. Thank you. That's correct. But I think it's interesting. If you look at half the people here are saying they've never seen it, but there are definitely some people that have seen it. Okay.
And in this case, we've got, it's time to get a chest CT. Mira told us there were blebs. Time to get a chest CT. Some people would admit with oxygen.
I think the chest CT part is really interesting because I don't know how it changes your management necessarily, right? You're going to assume that a kid with a spontaneous pneumothorax has blebs. You may or may not see them on the CT. So to me, I don't always understand what the CT tells you. If they've had bilateral pneumothoraces, then you know that they have.
Saying, Mira, everyone's saying to help to talk to the family. Some people say they agree with you. A lot of people are agreeing with you, but
I think it makes sense if you are going to consider, like, a kid has one-sided pneumothorax and you're going to do an intervention on one side and you're trying to decide if you're going to bilateral. That's them, and the family wants information. And I still don't generally do it then. But if you've had pneumothoraces on both sides, I think it suggests you have blebs on both sides. So what does it tell you?
That's what Stephen.
Well,
yeah, go ahead, Mac.
Well, we unnecessarily irradiated the patient, according to somebody, and we had put a left pigtail chest tube in, and the patient on CT scan, surprise, had small blebs bilaterally at both apexes. All right, so your plan now is treat only with the pigtail catheter that you put in the ED, left VATS with blebectomy and mechanical pleurodesis, bilateral VATS blebectomy with mechanical pleurodesis, or you can't take it and you want to do VATS blebectomy and chemical pleurodesis. So there's our question for the audience. Justin, since we're waiting.
Yeah, I think option A is totally reasonable. This is the first on the left side. The other one was on the right side, correct?
This is the other side.
Yes.
Now.
Yeah.
Yes.
So I think based on that Midwest Consortium study, if the quickly resolves with the pigtail, that's totally fine. But I think Mira is right. Like, this is a family discussion at this point. I wouldn't have got the chest CT, to be honest, but like, I think you just talk to them and let them decide. And I think if you do the pigtail, it's a pretty short period of time before you call it a failure and go to the OR, as far as I'm concerned.
All right, let's see the results.
I think that study out of the Midwest Pediatric Consortium suggested that if the aspiration fails, then chest tube's going to fail.
So Mac, Bob Letton and Joe Shalansky are both saying that, are you staging this or not? Which is, again, to Steve Lee's question. If you don't get do you always operate on both sides if you see the blebs? If you don't get a CT, why not wait for that to get symptomatic? Then if you do see them on both sides, you do them at the same time or staging. My answer is, if you're gonna operate on both sides, there's no problem with doing them. I wouldn't stage them. If I'm there, I would probably do both, I guess, which argues for the CT.
Well, Phil Frickman just said that you're doing cruel and unusual punishment if you do that.
You can't fix asymptomatic. I mean, he did have, this kid's different because he at least had one on the right side. So I think you can have that discussion. But getting chest CTs routinely and then seeing blebs on the other side that may never cause problems, you're probably doing a lot of unnecessary surgery.
I'm going to move ahead because time is not on our side at this point. In this case, the patient was treated with chest tube alone. He represents 3 weeks later with right-sided pleuritic chest pain and a pneumothorax. A 12-French pigtail catheter is placed. So now we've had 2 right, 1 left. We've been pretty conservative in the therapy other than irradiating him unnecessarily. So now what? We put the pigtail in on the right. VATS with blebectomy, 1 side, 2 sides.
So,
or something more aggressive.
Mac, while we're waiting for these to answer, I think the question about have you seen a kid with a tension pneumo or an extremis dictates all of this. If we believe that these kids are so low risk, then it's fine to wait to see what happens. If we believe that they're at high risk for getting a pneumothorax or they're at risk for a life-threatening problem, then you could argue for doing a prophylactic procedure. That's where I think where we really need to know the data on how often do we really see a risk of this, or is this just a thing you can wait for?
I also think a little bit
All
of
right, let's see.
thing, right? Like, where does the patient, are they somebody who travels to remote places, right? How likely are they to get to you if they do have a problem? You know, that plays a role, I think, in decision making.
He's an airline
All
pilot.
right. In this case, we're doing bilateral VATS at this point with mechanical pleurodesis. And because of time, Todd, I'm gonna go through the rest of this case, but we're gonna not get everybody to answer. So in this case, the patient had bilateral VATS and blebectomy and chemical pleurodesis, as the majority of people in the audience suggested they would do. Had a couple chest tubes. 3 months later, he shows back up with a new right-sided pneumothorax. Dang, now what? Do we repeat chest CT, chest tubes, back to the OR to do over, back to the OR to add something else? So Ted, keep up with me. We're not going to answer all the questions right this minute because I want to get to the other patients. And then in this case, he got another chest CT, more blebs were found, treated with chest tube alone. 2 months later, he shows up with another right-sided pneumothorax. He's now just being followed in the clinic with a small right-sided pneumothorax. So,
so before we go, there's a lot
on.
of discussion on pleurodesis here. I think we could do this next time, Mac. Chemical, mechanical, or nothing. I changed my mind after Samir Pandya showed me the data from the Chinese and Korean study that showed no difference between pleurodesis and non-pleurodesis. So I stopped since then, but I think we could have a whole thing about pleurodesis.
All right, this is an interesting case for us. A newborn with trisomy 18. I'll say it again. Trisomy 18 is having poor PO intake, no vomiting, is tolerating some NP feeds, and the parents and the neonatologist are requesting a gastrostomy tube. You recommend to get an upper GI or don't need an upper GI?
All right, what do people say? Mira, what do you do in Cincinnati? Justin, what do you do in Akron? So Mira?
We have a protocol for upper GIs, and we get them in particularly in chromosomal abnormalities. So this kid would get an upper GI in our system.
So it depends on the patient.
Mm-hmm.
Justin?
Yeah, I think, we're a little bit variable, but I think in general, definitely having any, genetic issues. In general, I usually get them if they can't tell you they have midgut volvules. But I'm starting to do less and less because I think it's mostly unnecessary. But
David Rothstein just told us to look with the scope when we're there. Here's our answer. It's split. 61% say yes, 40% say no. So that's still an area of controversy for us, I would say, Todd. In this case, you get an upper GI, and of course, it shows malrotation. And this is a trisomy 18 patient. So now what would you do? A laparoscopic G-tube, open G-tube, laparoscopic G-tube with LADs, open G-tube with LADs.
So now you have, just to clarify, this is what makes this interesting. So you have a trisomy 18 patient. Does that affect I'm just curious, yes or no, does that affect your decision-making that it's a trisomy 18 patient? And either way, then in this patient, would you do a LADS or would you not do a LADS? Mike Chen says, it sounds like most people are saying it doesn't matter.
I think it's a lot about the conversation with you have with the family. And I would agree that I think the 10-year survival for trisomy 18 is something like 10%, and the 1-year survival much higher than that. So I think it's a lot about the conversation you have with the family and what their risks are that they're willing to entertain and how you counsel them.
Interesting. It's really interesting what people are writing here. So
I think, there's definitely the portion of pediatric surgery that thinks, an open LADS is better or less likely to have recurrent volvulus, and that's a whole nother discussion, I think. But I would say like it's probably definitely worth starting laparoscopically to actually make sure that they have malrotation and that it's not like a non-rotation or something like that. Because I've seen people do open procedures for this and then find that they don't have malrotation, which someone said volvulus is no bueno. I agree that, but open surgery for a lap G tube or for what could have been a lap G tube is also no bueno.
I agree, but you know, it looks surprisingly 63% do a lap lads. And that surprises me because I thought, you know, a lot of people don't do that. I agree, but okay.
Rob Russell says you have no choice. You have to do the lads. So thank you, Rob.
Yeah, I think that's interesting. This is getting a great case because it looks like there's a lot of people just pretty much say that now. Okay.
In this case, the patient underwent an open gastrostomy and LADS procedure. I tell you what, I'm going to, Todd, I'm going to do that last case.
I agree.
Yeah, so Todd, Ted, keep up with me.
Oh, but that was a good one. Okay.
I know, hang on. Well, if we go back, if we have time.
Next year. Okay.
All right, here we go. 14-year-old male presents with a 2-day history of nausea, vomiting, fever, abdominal pain that has migrated to the right lower quadrant. On exam, he's tender at McBurney's point. On your exam, he's tender at McBurney's point. With some guarding, white counts 12,000. COVID antigen is negative. Ultrasound is equivocal. I'm sure no one's ever had that report before. So in this particular case, would you get a CAT scan? Mike Chen, would you put your comment back up? I missed it.
Barry Newman says, get an MRI. A lot of people saying get MRI. Whoa. A lot of people saying get MRI.
Absolutely.
Whoa.
Yeah. Good.
Love how cool.
MRI versus wow.
Yeah.
A lot of MRIs.
Okay.
So it looks like our majority would say 74% would not get a CAT scan. Some of those would do MRIs. So the 26% that say no, I guess.
Okay.
Okay. In this case, a CT scan was performed, and it's also read as equivocal for appendicitis. Now, what would you recommend?
Bernie's point tenderness, a history consistent with appendicitis, but a CAT scan and ultrasound that are equivocal.
I'll tell you later, David Rothstein. Send home on oral antibiotics, admit and treat with antibiotics, go to the OR for appendectomy. Those are our, or something else.
We got serial exams, we got MRI, we got administer and monitor, no bug juice. Okay. So you admit the kid, you monitor, and over the next, I'm adding this to this, Mac. The right lower quadrant tenderness does not improve. And let's say, I don't know, Justin, was he skinny?
Yes, very skinny.
Sharif Emil says lap appy. Mike Chen wants to know if he's skinny. Repeat ultrasound. How often does that help? I don't know. That's a great point. Appy. Observe. Can't we agree on anything? Observe, appy, observe, appy, operate, observe, appy, appy. Okay.
All right, let's see the results, Ted. Let's see the results. To the OR for appendectomy, over half.
Over half.
And then the something else. We need somebody to tell us the something else.
We got 4 minutes left, and which plenty of time. Tell us what you would do. Counsel the family. Don't let skin stand between you and the diagnosis. All right, we need other family history. What other family history do we need?
We got
for COVID.
We got 2 hands raised, and they're in the room here if they want to speak.
Bring it. We got 3 minutes left, and we're gonna hear Justin tell us what happened. When did he last poop? Who cares when he pooped? Why do you care when he pooped?
Todd, we've had a number of patients who have had a family history of COVID. They have signs and symptoms of appendicitis, equivocal imaging, and they have a syndrome much like that that's attributable to COVID. It's not appendicitis. That's why you need to ask the family members what their symptoms have been for COVID, and you need to interrogate that. I'd admit this patients and put them on antibiotics and not take them to the operating room.
All right, hold on a second. So
have a
I, for
penchant
some reason,
operating patients.
I can't see who's talking, but is that Mike Allshouse talking?
No, it's Casey. It's Casey, and
Is
I
that
understand why
Casey?
he's
Okay.
program chair. I understand why he's program chair now.
All right, that's Casey. For some reason, I can only see us four. But all right, so Casey, you're worried about COVID.
Yeah.
Yeah. All right. Okay. So
here, this kid goes to the OR, and in the middle of the case becomes hypotensive. So all of a sudden, anesthesia says, "Oh my God, he's crashing," and Justin's staring at the appendix that doesn't look real inflamed. What do you do now?
Justin, talk to us.
Todd, you altered this.
I altered the case. I altered
make me sound good, not worse. But
I made you look bad. This is not how the case went. But it's
my case. He had a CT. They read as appendicitis with an appendicolith. Not equivocal. But I will say in the OR, it was very underwhelming. And this scenario basically happened where anesthesia is like, "Oh my God, what is happening?" And
all right, so let's see the results, Ted. So half would leave the appendix and half would try to get it out real quick. All right, great. So just to finish this one up, in this case, the appendectomy was completed and the patient was taken to the ICU. Once in the ICU, there was a 20% ejection fraction and elevated things. Mom and Dad, now that we get a history, Mom and Dad described COVID symptoms 6 weeks ago.
You needed Casey there.
And the patient was diagnosed with MISC. So
in the last
interesting.
few seconds,
So
Justin, oh, sorry, go ahead. Sorry, Mac.
this is our final question, Todd, and then we can chat. So in the era of COVID, should we ever operate on appendicitis?
So my
Or
answer,
equivocal.
so I would say
Equivocal.
that here, in my opinion, is in the era of MISC, at least until this nonsense is over, we should not be operating on equivocal appendicitis. We just shouldn't. That's my opinion. It's a very strong opinion, at least for the next year or so until this is over, because it's just so high of a risk. That's my opinion.
Sharif agreed with you, Todd. People are agreeing with Todd. Oh my goodness.
That never happens.
All right, let's see the vote.
So Justin, that's why I modified the case, because if it says appendicitis, you're probably going to go. But if it's equivocal is the question I wanted to hit at.
I think now we have pretty rapid turnaround of COVID antibodies. When this case happened, it was like 3 days or something. I mean, it was kind of earlier in COVID. And this was like one of the first MISC patients that we saw. But he was like more tachycardic than you would expect for just appendicitis. So that was sort of one tip off. And then I think a fast test that you can get that would tip you off also is just checking a BNP. That will come back rapidly, regardless.
So let me just say that we're done. Our time is up, right? 7:45, we're done? Okay.
Yes.
Mac, we have the one case, so we don't forget, we're going to put that one we missed on next year.
Yep.
Any final thoughts, Mac, Mira, Justin?
No, this is
No,
awesome.
this was great, everybody. Thank you so much for participating. This is what makes this fun, all the comments and the voting. So appreciate it. I can't wait till we're back face to face, but this is great. Thanks, everybody.
Thanks, everyone, for having fun. This was great.
As
Wow.
expected.
Yeah. How do you really follow that, Kath? I mean, there's no way. Thanks, everybody. That was fantastic. And the chat is longer, and I hear you. There's always room to make this better. So we'll take that. Well, Kathy will take that under advisement.
Definitely. I think you could do this daily. And what I like about the moderators is they say it's going to be a rough session. It's really rough on them. I mean, I think all of the people in the chat are basically brutalizing the panelists. And I just think that's so much fun. So,
the one cool thing about doing this in this format as opposed to live is that you're not limited by Todd's ability to move around the room, and he's a pretty quick guy. but this way you get all kinds of input on the chat, which I think is really cool. I mean, I really want the in-person meeting because it is lively, and there's a lot of other reasons why I want that, both personally and for the organization. But this session, doing it this way, is really cool. So this is the last session of the day. We want to give you some introduction about how tomorrow is going to work. It seems like our AV stuff worked out pretty well other than that early snafu. So I'm optimistic that we're going to have a good day tomorrow. Tomorrow starts at 10 a.m. Eastern. That's 3 p.m. if you're in London. And I don't know, I can't go farther east than that. So 10 a.m. Eastern, 9 p.m. Central, 8 a.m. Sorry, 10 a.m. Eastern, 9 a.m. Central, 8 a.m. Mountain, 7 a.m. Pacific time. I got it. And we start with
our hosts of the day tomorrow are going to be Dave Lau, Jamie Golden, and Jason Frischer. They're going to start with Dave in the timeout. And so please, everybody log in so that you can see these three serve as your hosts of the day. And I'm sure they'll be much more entertaining than Casey and I were today.
So the big highlights of tomorrow is we have our first plenary scientific session, and me and Kathy are biased because that's essentially our part of the program is all the scientific stuff. There's 10 fantastic talks in there. Then a transition, and then we have a systematic review on gastroschisis, which I think you'll find fantastic. There is a quality, and we put together a quality and safety award finalists session. 2 abstracts of the quality and safety committee felt were the 2 best of that group that they'll be presented tomorrow. Then we have a lunch break with the industry session. We encourage you to tune in for that. If you can grab a bag lunch or order Jimmy John's or whatever. I mean, what do people use? The driving stuff where you get food, which my kids use it all the time, and I don't
like
know.
DoorDash?
DoorDash, there you go. You
Yeah.
can DoorDash your food. Perfect. Then so after that we have a tech talk, 2 tech talks. So the 2 new tech talks for this year, 2 out of 4, will be tomorrow. One is on intestinal rehabilitation, and the other one's on family-centered care. That's one with a parent, Ms. Cho, which should be fantastic. And then we end tomorrow with the presidential address by Dr. Waldhausen and the symposium, which is going to be a debate. Which you remember we did that back in Boston, and I'm really looking forward to that. And the question is, are we training too many pediatric surgeons? We've been talking about this for a while, but it's still it's a very passionate thing. We'll have 4 people that will, I'm sure, knock it out of the park. So that's tomorrow's program. We really appreciate you joining us today. Kathy, you want to wrap it up by saying anything else?
I think at that last session with Dr. Waldhausen and his panelists, everyone can get involved in the Q&A and the chat. And I know that people have a lot of opinions on that. So please tune in live for those panelists so that you can throw out your opinions into the chat and the Q&A.
Yeah, there won't be any live Q&A with the scientific stuff, right. But you can put a lot of those stuff in the chat in the Q&A and in the community question board. So thanks again for joining us on day 1, and we'll see you tomorrow at 10 a.m. Eastern time.
Thanks, everyone. Bye.